My name is Fahid Rasool. I'm a consultant neurosurgeon at Coventry Hospital, and what I'm going to be talking about today is spinal trauma. Thanks for inviting me to this study day. It's a great idea, and it's nice to be part of the region and the team as well. So, as you can see here, this is the big university hospital, and we've got a big helipad. You can see the hospital in the back. This is where we work, where the spinal trauma comes in. So what I wanted to talk to you about today is a few things. Early management of spinal trauma in the emergency department. That means what happens when the patient comes into ED, but also understand there may be some pre-hospital medics as well. So we can talk a little bit about pre-hospital medicine if anyone's got any specific questions. I want to talk to you about a few important facts about the spine that are related to spinal stability and really do affect your management of spinal trauma, how to interpret some of the imaging, and this is really mainly the form of x-rays to really try hone in on your skills and try and pick up some of the subtle issues that may be going on in the spine if someone's had some neck pain or some back pain. What is a stable versus an unstable injury? And then we'll talk about the non-operative management of spinal fractures. Clearly, if they need an operation, they'll go under the spinal team, the neurosurgery team, for treatment there. So just starting with some facts. As you can see, you've got the spine on the left, and the spinal column, the bony spinal column, encases the spinal cord, which you can see just here. So this is the dorsal aspect of the body, which we see here, the spinous process, which you can feel, and then and so around this spine, you've got the vertebral body anterior to the spine, and you've got the pedicles alongside the spine, and these are the transverse processes, and we'll talk about all these types of fractures coming up. The spine has a natural curvature, the cervical lordosis, a thoracic kyphosis, and a lumbar lordosis. And sometimes it's really important to know that, because losing the alignment of the spine on a plain and simple x-ray can give you hints about the injury that someone has sustained. So simple principles, really important, how to manage a spinal injury in the emergency department. It's all about your ABC always. One of the important things I think to remember is whether or not it's part of the polytrauma, if the patient's had multiple injuries, and if they have any systemic features of hemodynamic or cardiovascular instability. Something that I think is often missed and gives really important information is finding out about the mechanism of injury. And it's not just, lorry versus car, or cyclist versus pedestrian, or, fall down stairs. You want to know how many stairs did the patient fall down? What did they hit first? Was it their head? Did they fall onto their side? Do they have injuries in their shoulder? What car were they driving? Were the airbags deployed? What speed were they going at? These sorts of things, because that sort of changes your index of suspicion when it comes to spinal trauma. So the other thing is knowing about the patient's baseline, their past medical history. The reason for that is trying to get a baseline, and we'll come on to this a little bit later. When you look at patients who have medical comorbidities, elderly patients, even sometimes when they have unstable spinal fractures, they don't always get fixed. Sometimes a pragmatic decision may be just to manage them non-operatively with sort of early or gentle mobilization, even without a brace. And that's probably why, and I'm sure a lot of you have experienced this, you get lots of different advice from spinal surgeons about what to do. Do we MR them? Do we not? Do we just leave them in CT? Do they need a brace? Do they not? Is it stable? Is it unstable? Do they need an operation? Do they not? And because everyone's got a slightly different approach, but what I hope to give you today is some of the simple principles that we use that can be used in discussion with some of the specialists when referring patients and initiating this early treatment. The Asia score is really important. It's not something that's always done in the emergency department, but it is done as soon as the patient either gets to the ward or if it can be done in ED, I mean, that's fantastic. I mean, that gives us some objective information about, sensory level, motor level, bowel and bladder function, and things like that. And the other thing is whether or not the patient has features of spinal cord injury. So it's all well and good having a bony injury that's unstable, but has that caused impact on the spinal cord itself? Does the patient have a Cushing's response? Do they have bradycardia, hypertension, that sort of thing? Are there features of spinal cord injury? Because management of that extends from just the sort of external orthosis or surgery and things like that. So, I mean, I'm sort of, I know I'm talking to people who know all about this and much better than I do, actually, but ATLS principle is really important. Airway and space, C-spine, the first thing. That's not how you put on a collar. I'm sure none of you do that. Nice immobilization of the cervical spine, blocks. They'll come in on a board. They'll have tapes around them as well. You can see here how nicely the blocks and the collar is all nicely positioned. And this is just a little bit about how to handle the head, just to keep it nice and still and in line. So immobilize the C-spine, keep them on flat bed rest and log roll until you're safe. So if you've got any index of suspicion, keep them log rolled until you've got imaging or you can assess the neurology. As you know, a lot of them come in with head injuries, have impaired consciousness or have been intubated at scene, and therefore you can't assess them. In that case, leave them on bed rest, log roll them, do a CT whole body. That's standard trauma series now. Think about your adjunct, your IV fluids. There's no real role for steroids and spinal cord injury. It's been shown to be harmful for multiple randomized control trials. So what to do on admission? This is a bit more to do with acute medicine or if the patient actually going to the ward. It's, again, very similar to the principles of how you deal with things in ED. History examination, mechanism is very important. Ask about sphincter function. That can change your Asia score from B to D or similar. Do a full examination, check their power, their tone, etc. See if they've got a sensory level. And then do investigations based on what you find. If they have not already been done in ED, does the patient need an MRI, for example? So there's a few more facts about the spine itself. So different parts of the spine do different things. So the C-spine is a very, very mobile segment. It is important for head rotation. And if you have a head injury, you always want to consider whether or not patients had a C-spine injury. So just yesterday, actually, I had a patient who had a head injury, was intubated, was not in a collar, and had no CT of the C-spine or any imaging of the C-spine, and was on ITU. So we had to go back a step, put the patient back in a collar, get a CT of the cervical spine before clearing it because they're unaccessible. So those sorts of things are really important. Get a CT C-spine if you're getting a head a CT head as well. The thoracic spine is very important for maintaining posture. This is a really important point. It has additional stability provided by the ribs. So when we talk about bracing and things like that, if you have a mid-thoracic fracture and the ribs are intact, i.e. there's no polytrauma, there's no flail segment, then actually sometimes the ribs can provide that natural brace. So you don't always need to have a brace, and that's something to sort of consider. A patient has a natural sort of kyphosis, and although it's relatively mobile, you'll often see these sort of elderly patients who come in with innocuous falls from standing, and you'll see quite kyphotic deformities. So I mean, you can't see what I'm doing. So they're often hunched forwards, and then they put their the head up. So they exaggerate their cervical lordosis because their thoracic kyphosis is exaggerated. Lumbar spine is a load-bearing segment, so it's got big vertebra, big joints, and has a natural lordosis, often involved in axial loading, compression fractures. This is just a bit of detail about the Asia chart. I'm sure these are available in most emergency departments. If you can fill them in, that's really helpful for us in terms of getting an idea of baseline, particularly if a patient has evolving neurology or in the decision making about whether or not the patient would benefit from surgery or not surgery, or whether they've got spinal cord injury and where they go. Can they go to the ward, or do they need invasive blood pressure monitoring for ensuring they've got adequate spinal cord perfusion? We'll talk a bit about that in a minute. So you can assess the severity of the injury based on some of their hard neurology. If they have incomplete paraplegia or complete paraplegia, then it's thoracic downwards. If they have quadriplegia, then you're talking cervical. So they're very, very simple, basic, very quick, easy to assess. You know, if they're awake, they're on a board, can they move their arms and legs? If they can move their arms but not their legs, you know, you can kind of hone in slightly on the level of injury. What imaging do you get? So easiest thing. So now I suppose CT is very commonly done, particularly in major trauma centres, but in some of the district general hospitals, you know, you're still getting your basic X-rays, and we're just going to come on to what you can learn and what you can interpret from those X-rays. If you get an X-ray, you want to get AP and lateral views, and if you're getting C-spine, they've got high cervical neck pain, you want to get an open mouth view as well, which I'll show you in a minute. CT needs to have both sagittal, axial, and as is often part of the trauma series, you'll get high resolution, fine cut axial CTs, which you should be able to reconstruct to look at sagittal planes. An MRI scan, you want your T1, your T2. You don't need contrast in trauma situations, but you do need a stir. The stir is a fat suppression sequence, and that's particularly important. We always use it when you're looking for possibility of ligamentous injury. That can be the anterior longitudinal ligament, the PLL, the interspinous ligaments is really important. It often shows edema in the pedicles, which is not always picked up. So if you have a fracture of the vertebra and you're not sure whether it's stable or unstable, because it may be a two column injury within the vertebra itself, and we'll come on to that, the columns in a minute. What you want to know is whether or not it's extending into the posterior elements, i.e. is that fracture, is the swelling going into the pedicles and into the posterior elements, the interspinous ligaments, and the stir sequence is really, really useful for that. So the cervical spine X-ray, as I say, you 3 views, lateral, AP, and a peg view, you can get it. You want to be able to see all the way from C1, this is C2 peg, and this is what you want. You want to be able to see the facet joints, everything's nicely aligned, there's no sort of sagittal misalignment. You can see the spinous processes nicely with 2, 3, 4, 5, 6, 7, and T1. That's the perfect X-ray. I know that this is not always possible, but that's what you're looking for, and you want to be able to outline those bones, look at the spaces in between the vertebral bodies, in the facet joints, in between the spinous processes, and this can often be the thing that really alerts you. So if the space between these 2 spinous processes was increased, then that may be indicative of something going on here that you can't quite see on an X-ray, and you might get CT, and it shows the same thing, increased size in the interspinal space. And then an MR will show a ruptured disc, which shows that it's a highly unstable fracture, needs probably an operation depending on the patient. So there are subtle things that you can pick up on your X-rays that are really, really important. This is a swimmer's view, and it shows you just that little bit extra of the sort of lower thoracic, high cervical. So if you can get that, that can be useful. These are the things you want to look at. So you've got the clivus here. This is a really important thing to remember, particularly in patients who've had high-speed road traffic accident, high-speed trauma. You can often, well, not often, but you can get this atlantoaxial subluxation of dislocation, where literally a patient's head is ripped off. And the way to pick that up is that the distance between these is increased. So it's often of the order of millimeters, 5 to 10 millimeters. If it's much more than that, then you know the patient's had a devastating injury. You want to look at your alignment, your ALL anterior to the vertebral bodies, and your PLL. You want to make sure that that's all in line. This is the other one, the posterior margin, spinolaminar line, rather. And here you can see the spinal canal is going to be in there. So the spine lies in there. And that's important because it gives you information about whether or not you think there's been a spinal injury simply based on an X-ray. It can be really, really useful. You can also look at the prevertebral soft tissue. So it should be less than a third of the vertebral body width above the level of C4 and less than one below the level of C4. There is the rule of the 2772. At the level of C2, it shouldn't be more than 7 millimeters, and at the level of C7, it should be more than 2 millimeters. So the soft tissue can be indicative of injury as well. You want to look at your interspinous distance on an AP X-ray. So you've got there to there. You can pick that up. These are your pedicles here. These are your lateral masses coming in. These are your transverse process. These are the place that articulates with the ribs. So you've got your pedicle, the transverse process comes up there. And often you can see a loss of vertebral body height very well in an AP X-ray. This is a peg view. You can just about make out the peg there. And these are the lateral masses of C1. You have a C1 fracture. You can see that the C1 is splayed away from the C2 body and the rest. C-spine injuries, coming on to different modes of injury. Flexion, extension, rotation, axial loading, all combinations of the above. And these are the types of injuries you'll get with that. You'll see those on the X-rays, or you'll see them on a CT. This isn't something called the Esselig's criteria that we use. The Esselig's criteria can sometimes be useful for telling us whether or not an injury is stable or unstable, and helps us with our decision making in terms of surgery versus no surgery. There's the Jessens fracture I talked about. That's a C1 fracture of the C1 arch splayed out over the C2 dens and the body of C2. Also, there's a C2 fracture or a hangman's fracture, bilateral fractures of pedicles seen on CT, highly unstable fracture. These are Clay-Schoveler fractures, usually the spinous process at multiple levels, C-spine. In terms of thoracolumbar fracture, we talk about the three-column model, the anterior column, the middle column, the posterior column. If you have two columns that are injured, then that is an unstable fracture, an unstable injury. And so that's why I was talking about that MRI scan, looking in towards whether or not it affects the pedicles as well. Stability is really important, and coming on to, we'll come on to that in a minute. But again, knowing the types of fracture you get in thoracolumbar spine, and these are how they look. I can share these with you. Difficult to go through them in a bit more detail with limitations and time, but I can share this by sending it to you. T-legs criteria is really important for us, a bit like the S-legs criteria. T-legs is almost more important. It's very valuable in determining stability, predictors of outcome, but also helping in decision making in terms of surgery. We don't need to talk about that too much. This is not a common fracture that you get in ED, that wedge compression fracture, and often get it in osteoporotic patients. And it's really important to know whether they're new or old. And the CT will tell you, will be able to tell you that, or at least the report that you get from the radiologist. Look for cortication at the level of the fracture to indicate whether or not that's new or old. That's really useful. This is the burst fracture, and as you can see, there's retropulsion of the posterior segment of the vertebral body into the spinal canal. which is where the nerves and the nerve roots are. So you're almost inevitably going to get some level of neural injury or neural compression with that. Is it stable or unstable? So instability, it's a bit difficult, and there is a bit of discussion around this. But essentially, the instability is when when the spinal column is unable to tolerate your normal physiological loading without causing pain, deficit, or progressive structural deficit. And that's difficult to assess sometimes. And so sometimes it's easier just to see whether or not it's a 1, 2, or 3 column injury. 3 columns are definitely unstable. 2 column injuries are often unstable. 1 column injuries are not unstable. But these are the things that the neurosurgeons, spinal surgeons are considering when they look through the imaging and make decisions about treatment. If you believe, or if the patient has spinal cord injury, these are the types of things that you need to be looking at. So this is taken from a slide from before when I was in London. We used to refer to Stanmore. Here it's Oswestry, I believe, and there may be 1 or 2 other units around as well. I'm going to skip that a little bit. We can talk about that if necessary. A bit about the spinal cord syndromes and what you pick up on the neurology. Not so important from the emergency department. I'm sure you all know this type of thing. This is an important one because you often get this in elderly patients, that central cord syndrome, that hyperextension injury. Okay? So you get the upper extremities are more affected by than the lower extremities, and as I say, it's often because a patient has a background of cervical spondylosis, degenerative C-spine disease, which you'll see on the CT, and that they've just been pushed over the edge by what looks like an innocuous fall. And the treatment for this, again, is debatable. Some people advocate for early surgery. Some people believe that you should wait until patients get back to their baseline before deciding whether or not their surgery is necessary. We'll come on to that. Conservative management. So we're talking now. We don't need to talk about spinal surgery. What we do need to talk about is whether or not patients need a brace. Do they need a collar? How long does it need to be on for? There's not much literature, and that's probably why I'm sure you all get lots of different opinions from when you refer to specialists. Is it on for 10 weeks? When are they followed up? Is there a fracture clinic? These are the sorts of things that units need to have, and we certainly have those in Coventry, and I think it makes a big difference when you have a proper pathway for these patients. How much do you need to restrict a patient in terms of mobilization to the collar hospital? Are they going to be discharged? Do they need to be educated? Who can do that? Can the physios do that? Think about the patient themselves. They might not be compliant after discharge. You know, I had a psychiatric patient recently who we knew he wasn't going to be compliant with a collar, and so he had an unstable injury, and we wanted to fix it, and so we had to get the psychiatrist involved and you know, really assess his ability to make decisions or accept or refuse treatment. So those are the types of things you want to be thinking about. With this, I mean, I've talked a little bit about this transformational model towards virtual and telephone clinics. It's hard to follow up patients on the telephone like this, but if you are going to do that, then make sure they have an X-ray booked just prior to speaking to them, so you can be talking to them whilst you're looking at their X-rays as well. Most thoracic lumbar fractures can be managed non-operatively, and that involves compression or even stable burst fractures without neurological complications. That is to say that, you know, even if someone has an unstable injury, if they're very old and frail, you know, an operation is not going to, often not in their best interest, and you kind of have to have a pragmatic discussion about that. Explain to the patient whether or not what the risks are, what the benefits are. You know, isn't a little old lady who's quite kyphotic, are they going to tolerate a brace? Because a brace is not always, you know, something that's going to help the patient. It doesn't always you know, you often get this sort of thing where patients are advised, or advice is given to put patients in a brace for pain and stuff, but it's not always comforting. So each decision is sort of quite nuanced, really, and dependent on the individual. What are the main goals of the external orthosis? You want to maintain alignment, you want to minimize their motion, you want to reduce their axial loading and prevent that kyphosis or worsening of kyphosis. They do not play any role in spinal stability. Here's a Miami J collar, which is what we use. It's a Jewett brace here, which I find quite useful as well. It's not always used in all of the units. And that's about it. Oh, I hope I got through in time. So if you have any questions, happy to take them now.
Thank you so much.
I hope that was
and
useful.
Thanks for rushing through for us to get get through the material there. I found that very useful.
More than happy to go through any questions. I will share these slides with you as well, and you can sort of pass it around to the delegates and things. I could go on all day, obviously, about this sort of thing, but if anyone has any specific questions, then please do ask.
That's lovely. There are some questions coming up in the chat there.
Can I see them? Let me just double check if I can see them. Yeah.
So I can see that Caroline's put a question there, which I can read out, or Caroline can say it. I don't mind.
Yeah, do you want to read it? Because I don't think.
Yeah, no problem. So Caroline Leach is asking, do trauma units need to refer you patients with a spinous process fracture or transverse process fractures of the C-spine, and also spinous process fractures of the
So look, I've actually spoken to Caroline about this. It's a really important question, so I'm really glad that you brought it up in this forum. Actually, look, if you've got isolated spinous process fractures, then that's by definition is a stable fracture, and it's going to cause pain. It doesn't really need much doing. There is something called the Clay-Schoveler fracture, where there are multiple contiguous fractures. I don't think a collar or a brace really helps with these. They certainly don't need an MRI scan, and I know trauma units are still doing this, unfortunately. So the answer to that is, do they need to be referred to us? No, as long as there is a clear protocol or defined pathway that identifies that TP fractures and spinous process fractures are stable fractures, as long as they're isolated fractures, even if they're multiple levels. They don't need further imaging in terms of MR. You don't need to restrict their mobilization. They need to be treated for pain. They don't need any external orthosis. I hope that's definitive. I hope that was the question.
Let's have a look. Does anybody want to put their hand up to ask any questions there in addition?
There is another question from Caroline, and she's put a publication on that this systematic review from Portugal advised that orthosis seems to add no benefit in conservative treatment of acute thoracolumbar fractures. What do you think?
Yeah. No, you're absolutely right. So the problem with a systematic review and often a meta-analysis in terms of the level of evidence is that it is only as good as the quality of the evidence that it is summarizing, i.e., and that's often, particularly with this question, class 3 and class 2 evidence. There's not much in terms of randomized control trials and high quality, high volume data, which is why when you put it all together, you can get numbers and often perform statistical analysis on it. I think there is a role for orthosis in thoracolumbar fractures. I agree that they are overused. I think that for specific patients in very specific circumstances, and I mean unstable thoracolumbar fractures where a patient is competent and has refused surgery, a patient is unfit for surgery. Those are the types of situations in which I think a brace can be helpful. In some patients, I do believe it does provide some level of pain relief as well, although that's limited. I think the issue we have with bracing is that it's an easy option for people when they recommend treatment, and they often just say put a patient in a brace for 12 weeks, and then that's decision made. But there's a whole that's a whole area that needs to be clarified.
Thank you very much. Are there any more questions at the moment on this acute spinal injuries presentation? Thank you so much. That was really helpful. And
not at all. Yeah, no, I hope it was helpful. I'm always happy to be contacted about anything in terms of spinal trauma, yeah, we obviously provide a big service to the region as well, and we are trying to go through some of our pathways as well, just to improve that alongside Caroline and the rest of our trauma team. So thank you.
Mr. Russell, just before you go, just in case anyone has missed this presentation, as I said, I will put the links on our website, but if they have got any, one-on-one questions, is it okay if they send them to me and I sort of put them together for you?
Yeah, for sure. Please do. Please do.
Wonderful. That's brilliant. Thank you very much for your time today.
Thank you so much, everybody. Thanks so much again, and all the best. Enjoy the rest of your day. Take care.
You too. Bye-bye.
Thank you. Right, that's lovely. Now I can see that Radhe Raghavan has joined us, and we will move on to her presentation on management of trauma in obstetric patients when you're ready.
Sorry to interrupt. I'm just concerned about the time, because it's not due till 10 past, and again, if people are coming on at sort of 5 past to see this presentation, again, they may miss the beginning of the presentation. Sorry.
I'm sorry.
Yeah, no, it's okay. These things are sent to try us, aren't they? I'm just thinking if we can just, if Radhe doesn't mind, just if we keep to time now, and I think it was due on at 10 past 11. Yeah. As I say, I think if people are looking at the programme, think, oh, I'll come on at 5 past 11 because that's the presentation I want to hear, that they'll miss it.
Yeah.
Because we're a little now ahead of ourselves.
Okay.
Is that okay? So it literally just give it 5 minutes. Yeah, as I thought, there's new people coming in and logging on.